So again, welcome to our new channel. Please like, comment, share, and subscribe. So today in our first video, we're going to talk about Alzheimer's disease. Alzheimer's disease is a progressive central nervous system disease that primarily affects the memory. But as the disease progresses over time, it affects other functions of the brain. This includes language, perception, attention, motor skills, orientation, problem solving, and executive function. So it's a neurodegenerative disease, which means degeneration of neurons of the central nervous system that starts slowly and progresses over time. Alzheimer's disease is the most common cause of dementia, and dementia is the decreased ability to think and remember. This develops gradually and interferes with the ability of the brain to function. Before we go any further, there is something called mild cognitive impairment, and this is just a stage between the cognitive decline of normal aging that everybody encounters and the more severe decline that happens with Alzheimer's disease. So the decline here is not severe enough to interfere with daily activities. So it's not a dementia per se, but it does increase the risk of dementia over time. The risk factors for Alzheimer's disease includes age. Age is the most important risk factor, so increasing age increases the risk of Alzheimer's disease. Positive family history is encountered in cases of familial Alzheimer's disease. Other risk factors include depression, cardiovascular disease, poor education, and multiple brain traumas. The pathophysiology of Alzheimer's disease includes the deposition of something called neuritic plaques and also something called neurofibrillary tangles. The neuritic plaques are basically amyloid deposits that becomes deposited in the extracellular space between neurons. So it impairs neuronal conduction and eventually leads to neuronal death. So the first substance, as we said, is called neuritic plaques, and these are deposited extracellularly. These are amyloid beta peptides that's derived from the amyloid precursor protein. This amyloid precursor protein is a transmembrane protein that's present in many tissues, but it's concentrated in the synapses of neurons. So it's present in large quantities of the neurons. This amyloid precursor protein is encoded by chromosome number 21. And as we remember, chromosome number 21 is the chromosome that becomes tripled in Down syndrome. So Down syndrome patients have 3 copies of this chromosome, and that explains why in Down syndrome patients there is an increased risk of developing early onset Alzheimer's disease. This is just a simple draw to explain amyloid precursor protein and amyloid beta peptide. So here is the transmembrane amyloid precursor protein. It becomes cleaved by a series of secretases. There is the gamma secretase, there is the alpha secretase, and there is the beta secretase. When this peptide is cleaved by the alpha and gamma secretases, it becomes cleaved into smaller peptides that becomes easily removed from the extracellular space. But when the activity of this beta secretase becomes more, this peptide becomes cleaved into something called amyloid beta peptide. This amyloid beta peptide is unfortunately insoluble, and it becomes deposited in the extracellular space over time. It usually becomes cleared by the microglia and other cells of the central nervous system that clears up the extracellular space. But for reasons we don't know, there might be increased production of this amyloid beta peptide, or there is decreased clearance of this peptide. So this leads to the accumulation, and as we said, this impairs the neuronal conduction and leads to the neuronal death. This amyloid beta peptide is also the major pathophysiology of another disease process called cerebral amyloid angiopathy. And in order to explain this, I've just drawn here a simple draw of a cerebral artery. This is a cerebral artery. The blood flows through the cerebral artery into smaller and smaller branches and smaller arterioles until it reaches the very small terminal branches. These small terminal branches are actually the branches that supplies blood to the cerebral hemispheres, which are also called the brain lobes. So in patients with cerebral amyloid angiopathy, this amyloid peptide becomes deposited in the walls of these small terminal arteries. They make them weakened and they make them liable to rupture. So, if you encounter cases in elderly patients with recurrent lobar hemorrhages or recurrent hemorrhages into the cerebral hemispheres, you should think about cerebral amyloid angiopathy. Cerebral amyloid angiopathy is not the most common cause of intracerebral hemorrhage. The most common cause of intracerebral hemorrhage is actually hemorrhage because of rupture of these deep penetrating arteries. And why is that? These deep penetrating arteries are branches that comes off the major artery stem immediately without tapering like the other branches. These branches off immediately from the main artery. So the pressure within these arteries are very high. So in patients with high blood pressure, these are actually the arteries that's more liable to rupture. So the most common cause of intracerebral artery is actually rupture of these deep penetrating arteries, not those lobar arteries. So, as I said, if you encounter a case of recurrent lobar hemorrhages, this is more likely to be cerebral amyloid angiopathy, not bleeding into these deep penetrating arteries. These arteries bleed into deep brain structures like the internal capsule or the caudate nucleus or the thalamus or other deep brain structures. The other substance is called neurofibrillary tangles, and these are intracellular substances. These are basically deposits from what's called tau protein. This tau protein is a protein that helps with microtubule stabilization. And what happens is this tau protein becomes hyperphosphorylated. And when it becomes hyperphosphorylated, it becomes insoluble. So it becomes deposited within the neurons in the central nervous system. How this is actually affecting the pathology of Alzheimer's disease, nobody really knows. It's not really well understood, but this is what happens. So neurofibrillary tangles are hyperphosphorylated tau proteins that becomes deposited inside the neurons in the central nervous system. And this is just a simple draw to explain or to emphasize that neuritic plaques are extracellular deposits and neurofibrillary tangles are intracellular deposits. So grossly, if you look at the brain of these patients, you will see diffuse cortical atrophy, which means widespread atrophy of all the lobes, and with secondary enlargement of the ventricles, something called hydrocephalus ex vacuo. It's just basically the enlargement of the ventricles because of the loss of the brain substance. This is a picture from the web, from Wikipedia, just to explain this more. On the left side, there is the normal brain with normal-looking ventricles, normal-looking gyri, normal-looking sulci. But here on the right side, you see this brain atrophied with widening of the sulci and narrowing of the gyri. There is loss of the brain substance with secondary loss or with secondary enlargement of the ventricles. This area right here is called the temporal lobe. And this part of the temporal lobe is called the medial part of the temporal lobe, which contains an important structure called the hippocampus. The hippocampus is one of the earliest places where these amyloid deposits becomes deposited in the brain. And that's why the hippocampus is one of the earliest areas in the brain to be affected. And what's the function of the hippocampus? It's the memory. It's the short-term memory. So that explains why short-term memory is one of the earliest losses that happens with Alzheimer's disease. So again, the first area to be affected by these amyloid deposits is the hippocampus, and that's why memory impairment is the earliest clinical manifestation. And just also to keep in mind, the hippocampal pyramidal cells are the most sensitive to ischemia as well. So basically these hippocampal pyramidal cells, because these are highly active cells, because these are the cells that processes our memory, they are very active all the time. They are very sensitive to any kind of insult, whether it's ischemia or deposit of abnormal substances. So that explains why they become early affected in Alzheimer's disease. Talking generally about genetics of Alzheimer's disease, There is this amyloid beta peptide we already discussed, that's in chromosome number 21. And as I said, that's why in Down syndrome there is an early onset, that's usually before age 40. There is also another genes called presenilin 1 and presenilin 2 that encodes for proteins that helps to regulate the activity of this gamma secretase. And that also explains why people with mutations in these presenilin 1 and presenilin 2 develops an early onset of Alzheimer's disease. There is a group of apolipoproteins that some of them actually protects and some of them increases the risk of development of the disease. So apolipoprotein E2 actually is protective. It enhances the breakdown of this peptide. But apolipoprotein E4 increases the risk because it's less likely to enhance the breakdown of this peptide. So, talking about the clinical features of Alzheimer's disease, the major and the earliest clinical feature is memory impairment. Recent memory is more affected, distant memory is more spared, but as the disease progresses, there will be also involvement of the distant memory. So as the disease progresses, there will be language impairment, there will be word finding difficulties, and anxiety, irritability, and depression as the patient starts to find difficulty with his daily functions. As the disease progresses even more, urinary incontinence, complete loss of speech becomes evident. Then the patient becomes bedridden, they cannot feed themselves, and they will finally eventually die because of infections like pneumonia or ulcers. There is a rare variant of Alzheimer's disease called posterior cortical atrophy, where there is more pronounced atrophy of the posterior or occipital lobes. The occipital lobe, as we know, is more involved with visual processing, so we can expect early visual problems in these patients like reading difficulties and problems recognizing objects and many other deficits that has to do with the visual functions. The diagnosis of Alzheimer's disease is merely a clinical diagnosis, so it's just a diagnosis of exclusion. So after excluding all other possible causes of dementia, then we can diagnose Alzheimer's disease. And as we said earlier, the MRI will show diffuse cortical atrophy and hydrocephalus ex vacuo. The differential diagnosis includes a multitude of disorders. The first one is called frontotemporal dementia. This is a progressive degeneration of the frontal and temporal lobes early on. So there is more significant changes in behavior and social misconduct. These patients tend to have inappropriate social behaviors even before the development of dementia. They will also have problems with executive functions because it requires complex planning, and this is the function of the frontal lobes. So damage of the frontal lobes will affect the behavior, will affect the social interactions, will affect the executive functions, even before the full-blown dementia. And here is a picture from the web just to show how the frontal lobes can be involved and atrophied more evident than the rest of the lobes of the brain. So if we see this, we should think about frontotemporal dementia. Next is Lewy body dementia. Lewy body dementia is a dementia that's characterized by the deposition of a substance called Lewy bodies in the brain neurons, which is made of alpha-synuclein. This Lewy body dementia is characterized by disorders during REM sleep. During REM sleep, for example, we have sleep paralysis. Patients with REM sleep disorders, they don't have this sleep paralysis, so they tend to act out their dreams. And they tend also to have visual hallucinations. So if you're encountered with a patient with dementia and visual hallucinations, you should think about Lewy body dementia. Also, these patients might have some extrapyramidal side manifestations like rigidity or resting tremors. Next is Parkinson's disease dementia. Parkinson's disease patients, they tend to have dementia as well. So the presence of extrapyramidal signs is very suggestive of this Parkinson's disease dementia. Next is normal pressure hydrocephalus. This is a classic triad of gait disturbance, mild dementia, and urinary incontinence. Urinary incontinence, remember, is just a late sign. These manifestations happens because of the compression of the nearby white matter by the enlarging ventricles. Because of the buildup of the cerebrospinal fluid within the brain ventricles, they tend to compress on the nearby white matter, and this is what causes these manifestations of gait disturbance, dementia, and urinary incontinence. The pressure tends not to increase too much because of the widening on the ventricles on the expense of the nearby white matter, so that's why it's normal pressure hydrocephalus. A classic diagnostic and therapeutic procedure in these patients, when we do lumbar puncture, their symptoms rapidly improves, and this is very suggestive of this disorder. Next is something called Creutzfeldt-Jakob disease. This is a very rare disorder of abnormally folded prion protein. Prion protein is present in normal brains in alpha helical structure, but when these prion proteins becomes beta pleated, they become abnormal, they deposit, and they tend to affect the normal alpha helical prion proteins to become again beta pleated prion proteins. This is a rapidly progressive dementia and myoclonus. This is very suggestive of this disease if you see a patient with very rapidly progressive dementia and myoclonus, and also this is a very rapidly progressive disease where death happens within 1 year of the onset. Again, most of the cases are sporadic. Sometimes it's familial, but it's very rare, and also it's infectious, so gaining this protein through some kind of transplant like corneal transplants can cause this disease. HIV dementia is dementia because of HIV infection. Patients will have low CD4 count and high plasma viral load. Vascular dementia is a dementia that's happening because of multiple strokes. So the dementia here, or the cognitive decline, follows a stepwise approach where patients have normal periods intervening with periods of stroke, normal periods, periods of stroke, normal periods, periods of stroke. So this is like a stepwise approach or a stepwise decline in the mental function. These patients will have the risk factors for cardiovascular disease like diabetes, hypertension, and hyperlipidemia. So these constellation of manifestations suggests vascular dementia. Neurosyphilis is a very rare disorder where syphilis progresses into tertiary stage. With the advent of antibiotics, this is really happening nowadays, but just to mention, if patients with syphilis develops or progresses to neurosyphilis or the tertiary stage of syphilis, they will happen to have degeneration of the dorsal columns. Here are the dorsal columns, which are responsible for vibration and position sense. They will also have atrophy or degeneration of the dorsal nerve roots over here. Atrophy or degeneration of the dorsal columns will cause sensory ataxia. These patients lose the information that's coming out to the brain from the peripheral muscles and peripheral limbs. So when these patients close their eyes, they tend to lose all the afferent sensory input from our body to the brain. So the patient tends to fall to the ground because they don't have any information that's going to the brain, that's informing the brain of our position in space. So this is called sensory ataxia, and this is very suggestive of destruction of the dorsal columns. Also, these patients, as we said, have degeneration of the dorsal nerve roots. So the dorsal nerve root degeneration will cause loss of the deep tender reflexes. So if you see a patient with loss of deep tender reflexes and normal muscle strength, this is very suggestive of degeneration of the dorsal nerve roots, and might be very suggestive of neurosyphilis. Another important manifestation in neurosyphilis is what's called Argyll-Robertson pupil, and that's because of degeneration of the pretectal nucleus. So the pretectal nucleus is responsible for the light reflex. So these patients will lose the light reflex. And since accommodation is a different reflex with different centers of the brain, they tend to preserve the accommodation. So Argyll-Robertson pupil means loss of light reflex with preservation of accommodation, and basically this is because of damage to the pretectal nucleus. Patients with neurosyphilis, they will also have some form of dementia. Other causes of dementia might include hypothyroidism, B12 deficiency, depression. Our lab investigations should include these disorders, and this will help to rule out these differentials. Finally, things to consider, and this will also help us to explain or to understand the medications that we give to patients with Alzheimer's disease. First, we need to talk about something called the nucleus basalis of Meinrad. What is the meaning of nucleus basalis? This is the forebrain, and this is a picture from the web again from Wikipedia. This is the forebrain, and this is the basal part of the forebrain. So this nucleus is present in the basal part of the forebrain, and that's why it's called nucleus basalis. This nucleus is the origin of acetylcholine neurons that supplies the entire brain cortex. And this acetylcholine helps with alertness, wakefulness, and memory consolidation. So you can imagine if there is a dysfunction of this nucleus basalis and decrease in acetylcholine levels in the brain, patients will have a progressive decline of mental functions. So that's why right now there is a lot of trials about deep brain stimulation of this nucleus. And there is a lot of promise regarding deep brain stimulation of this nucleus. This might help patients with Alzheimer's disease to improve their symptoms and to improve their overall mental functions. The next point to consider is what's called glutamate excitotoxicity. Basically, excess glutamate in the brain can cause neuronal death. So if we block the glutamate receptors, so we can block the excess glutamate or the excess effect of glutamate, this can help to reduce or to minimize neuronal death. The third thing is oxidative stress. Usually during the metabolism of our cells produce reactive oxygen species. These reactive oxygen species are reduced by reducing agents, which also produced by the cell's metabolism. So when the amount of these reducing agents are less, or when there is excess production of reactive oxygen species, cell death can develop. So if we give antioxidants like vitamin E, this might help to slow the process of cell death or neuronal death. So these three important points helps to explain the medications that we give in patients with Alzheimer's disease. The nucleus basalis of Meinrad, the glutamate excitotoxicity, and the oxidative stress. So the medications for Alzheimer's disease includes anticholinesterases like donepezil. These are centrally acting because they are capable of crossing the blood-brain barrier. They raises the level of acetylcholine in the brain, so they help with the overall functions of the cerebral cortex. NMDA receptor blockers, they block what we talked about, the glutamate excitotoxicity. An important drug in this category is called memantine. And finally, the antioxidants like vitamin E to slow down neuronal death. And that concludes the video on Alzheimer's disease. This is just an example of a question about Alzheimer's disease. You can read it on your own and answer the question in the comment section. Thank you very much and hope to see you next time.